Yep,
Me?
here. Yep.
Perfect. All right. All right. Well, thank you all for joining the webinar today. So this is session 9 of 10. And like I mentioned, we are offering nursing contact hours after each of these 10 sessions. They are recorded. I do know that we are having some technical issues on our end at Mountain Pacific for getting those recorded sessions available on our website. So just be patient. We will try and get that resolved as soon as possible. The next and final session is going to be March 24th at 3 o'clock Mountain Pacific time. And it's going to be regarding bringing it home and talking about how family and caregivers can be part of this, the trauma-informed care solution. And there we will be polling questions as well that we'll bring up today during the webinar, and also a link to the evaluation towards the end that will be placed in chat. So please make sure to watch out for that. And I do need to know if you are claiming nursing CEs today. So one of our polling questions is whether or not you are a nurse. So please answer that if you are, or if you missed it, thank you for pulling that up. You can, like I said, you can email me and I'll put my email in chat. So you'll have the ability to unmute yourself. When Dr. Gomi is presenting though, feel free to stay on mute so we don't have any background noise, but he does like it to be more interactive. He likes questions and comments and things, so feel free to enter those in chat or take yourself off mute. So after I introduce the speakers, they will recap what was discussed during the last session on February 24th, and then I'll work, I won't work, then they will start on this week's topic of cognitive behavioral interventions in nursing homes. So our speakers, Dr. Eric Arzubi, he co-founded Frontier Psychiatry in 2019 to introduce an accelerated, more aggressive response to Montana's growing mental health crisis. He served as chair of psychiatry at the Billings Clinic for 5 years, during which time he led the creation of Montana's first psychiatry residency program and Montana's first empath unit for emergency psychiatric care. Before moving to Montana in 2013, Dr. Arzubi spent 10 years at the Yale School of Medicine, where he earned his MD and completed postgraduate training in general psychiatry and child adolescent psychiatry. And our other speaker, Dr. Reza Gomi, holds a BS in computer engineering from Rensselaer Polytechnic Institute, MSc in biomedical engineering from Johns Hopkins University, and an MD from the University of Massachusetts. He completed a residency in psychiatry and a fellowship in movement disorders and behavioral neurology at the University of Washington. He currently practices neuropsychiatry with a focus on cognitive, memory, and movement disorders. He is also active in engineering and clinical research, focusing on using advanced technology, such as voice recognition, to track and monitor treatment of neuropsychiatric diseases such as depression, schizophrenia, Alzheimer's, and Parkinson's disease. So,
go Reza. Sorry, I had to do that. Sorry, Sarah.
And as you can all tell, he's got a very good sense of humor. The floor is yours.
Cool. So let me share my guy here. Noise. Okay. Cool. Slide. Where's the stupid thing? Okay. Everyone can see the screen okay?
Yes, we can.
Awesome. Okay. So the journey is almost over, my friends. Some of you may be very happy about this, and hopefully that's not many of you. Today's the 9th of our 10 talk series focused on trauma-informed care in nursing homes, with focus on several different specific areas. Today's is cognitive behavioral therapy and how we may use that in our work in nursing homes with and without access to formal therapy. So we kind of want to look at the traditional approaches and then talk about how we can adjust that and use some of these interventions ourselves. And as Alona mentioned, in a couple of weeks will be the last one in this series, and then we'll be kicking off another series 10-part series Dr. Seiss will be leading. So stay tuned for that. Same disclosures as previous. Again, just highlighting the overall curriculum. It's really flown by. So back to our review, which we like to do each week to highlight for those of you who have or have not been present before, but just sort of really reinforcing some of these messages. Part of the reason, at least the series was kicked off, was because trauma-informed care, of course, is now a requirement, but really we hope the reasons for that's a requirement from what I can see is that it's an evidence-based requirement so that people will do better in our facilities with education and training in this area. So I keep coming back to these couple figures from Dr. Arzoubi's first talk, which gave a nice overview of what trauma is and where it comes from, and noting that there's a wide range of adverse experiences you can have, many from childhood that carry throughout the lifetime, and not just the sort of typical ones we think of, but really the various forms of dysfunction that can lead to long-lasting effects. And then we really highlighted those effects and that can really take a multitude of presentations. So not just the depression and anxiety and those sorts of things, but also direct impact on your health and physical health. We jumped into a quick little overview of a study we did with Lewistown, Montana, with the Montana Mental Health Nursing Care Center there. This was an example, and this tied a little bit into our quality improvement and topic on pharmacology, where a couple of our outcomes here were focused on reducing medications. So this was just to kind of give you all an example and hopefully show you that these little kind of pilots, these little studies, don't have to be intimidating. You can kind of come up with a plan, talk to your leadership, and jump in with an idea. So we're hoping that this leads to quality improvement projects across the board with the audience. Loneliness in nursing homes, that was a separate topic just because it has such a huge impact on outcomes for people and how they do in nursing homes. And so we pointed out that the staggering effects of loneliness, interesting timing to be doing that, perhaps the most lonely year in history when we talk about the impact of the pandemic and what it's had on our residents and ourselves. And we try to highlight what to do, things to be implementing in the nursing home that are relatively easy, quick, and have enough of an impact that they're worth considering. Especially, I think I find myself fighting the sort of thoughts of, oh, I'm not sure how much this is going to help, or it's hard, sometimes I have a hard time finding motivation, but I've done these things enough at both small and larger scales to see that they have a positive impact. So it's worth the trying. So I hope some of you, if not all of you, have taken some chances here and tried some of these interventions out. We spent a lot of time on dementia because the majority of our older adults in nursing homes do suffer cognitive impairment, and much of that is in the form of dementia. And so we talked about the language around dementia and how important it is to be careful with that, because it really helps us identify people and what their needs are, and helps also plan for them and their families. Excuse me. And so we talked about how dementia really is an umbrella term. It's talking about a big grab bag. It's kind of where everything gets thrown under. So Alzheimer's, and I do a lot of explaining this with patients, patients that are residents of nursing homes and my outpatients. Dementia is not, it's a severity level. It's how you're doing. It's not a diagnosis that refers to any specific disease. So Alzheimer's is a type of dementia. And that's perhaps one of the most important things to keep in mind. So some people will say, oh yeah, I have dementia, but not know exactly what's going on. I like to really hammer in this slide because it helps us remember that when we can be reassuring versus when we might have our flags kind of up for something that might be going on that's more of a disease. And so some of the natural changes with aging, which we all probably have noticed to some degree, even for those of us who are younger, in terms of spatial orientation and processing speed, things that naturally go down with time, and will prompt questions. And even for those people that are already living in nursing homes, many of them will feel like they're losing cognition, but really it's still some aging, or it's secondary to medical comorbidities, such as sleep apnea, untreated anxiety, other attention issues. And then this slide is really highlighting something to kind of keep on your radar, and you will start seeing more of this in medical records that are coming through your facility and patients' histories, where they're able to now detect with biomarkers earlier and earlier in life, which is super helpful for detecting dementia and various causes of dementia. And specifically, when we do things like a spinal tap to check for that amyloid or tau, or we do a specialized PET scan, that just helps us. Some of these are obviously more invasive than others, but the methods are becoming less and less invasive. They're becoming faster and easier to access. And this will make a big difference with patients knowing what's going on in their brains, but also for us as providers, all of us here, to really be able to reframe and know how we're going to approach somebody. Because a lot of what we're dealing with now is just simply lack of information. And then the sort of, the question I get asked relatively often from colleagues, and again, it's easy to fall into these thought traps for much of what we do, I think, in nursing homes. But really, again, I try to reinforce that based on my experience every single week that I've been doing this, it's a very rewarding process. So spending time giving education and talking about dementia and what it is, but cognitive impairment in general and other health impacts of cognition is rewarding. It gives people knowledge about what's going on, and it also points out where the strengths are and what to focus on. And we're actually going to touch on that today when we jump into the CBT portion of the talk. So a lot of cognitive behavioral therapy has to do with focusing on strengths and reframing sort of cognitive errors that we tend to make in thinking patterns. Here is some of the areas where we can really focus on for people, and this applies to those of us taking care of the people in nursing homes. That yes, there are things, and in the early life on this graph, you might put in the adverse childhood experiences, things like that, where things that you just don't have control over as a person. I mean, these are things that unfortunately kids don't have control over. So their education level is determined by their environment, their community, their parents. It's not necessarily something like your 5 or 6 year old can't decide what their education level is going to be. Now, with that community support, of course, some of these things are harder to address, but it's never too late to learn. I mean, we have residents that pursue, the nursing home advanced degrees or online learning. The nice thing is now a lot of education can happen online. But then really moving into midlife and later life, these are all things that we can address in our facilities actively. So I think I've mentioned to you all before that I use the whole dementia risk as a way to scare people into using their hearing aids. So I have, especially with some of my older guys that really have a hard time using it, when I mention this, how big this risk is, that's usually a big motivator. And you can kind of see going down the list, but TBIs, hypertension, alcohol, obesity, especially for those of our patients that have vascular dementia, it's really, really important to be aggressive about their blood pressure, their cholesterol, their diet, because that's something we can stop. So we don't want that vascular dementia, the vascular disease to continue. And smoking, depression, social isolation. So CBT is actually a treatment for many of these things. And you could use CBT, cognitive behavioral therapy techniques, to motivate someone to use hearing aids, all the way to treating their depression, looking at their thought patterns around depression. So it applies to all of these things. So the CBT techniques we're going to be talking about, keep in mind, can be used to approach any of these. So trauma, of course, CBT is a good track record with, but really any behavior you're trying to encourage in one of your residents. And that might be behavior you're also trying to discourage for those of our residents that have a really hard time with what's going on around them and some of their cognitive decline. They might be doing things that are difficult to understand, difficult to manage. And CBT offers a way to approach that in an organized way. We touched on delirium. This is super important. So something we wanted to dedicate an entire talk to, because delirium is something we've all seen and will see. And for some patients, it's unfortunately repetitive and common. But we talked about delirium being, a state. It's a state that your brain enters into for various reasons, often related to medical issues, often related to dementia, like being coming out of surgery, having a UTI. And so you're inattentive, you are unable to pay attention to things. It can really fluctuate wildly during the day, different times of day. There's not an obvious other, reason, like such as, you fell and hit your head. It's really generally related to a medical illness or dementia. And so these are things that signal an emergency, because people can really be at risk for hurting themselves without knowing it. A lot of times after recovering from delirium, some people will remember it. Some people will say, wow, I really remember being really confused. But often people will say, they don't even remember this period, because their brain is just having such a hard time processing things. So being on the lookout for delirium, super, super important for people. And for us, because we, as those on the front lines, those of us on this talk today, often we're the ones that are going to highlight this and call out for help. So this is not something typically that a patient's going to bring up and ask for help with. So this is one of those really important things. And delirium will often have content that's related to earlier life traumas. And so that trauma-informed care really comes into how we handle delirium, because if we're not careful, we may approach someone and say, oh my goodness, they're acting really differently and bizarre. I'm going to put them in restraints, or I'm going to, you might approach them differently. And so we want to stop and pause and always ask, why is this thing happening? Because chances are, especially for our older adults in nursing homes, there's always a reason. And so taking a pause to know what that reason is will help you both identify delirium, which is a medical issue and needs to be treated, and reframe what you're observing to allow you to approach it in a calmer and more loving way. So and that's something we know that across the board will help with outcomes. And you can see here it's a circle. I mean, it's sort of like a cycle that goes in both directions. So if you restrain a patient because you're worried that they might hurt themselves or someone else, they're also much, much more likely to have delirium. And if they have delirium, they're more likely to get restrained. So, we have to really think about how to break that cycle in these cases. And often, we have to prioritize what's safety first. And I guess part of this series is to push everyone here to consider just, slightly taking that extra pause, thinking about what's causing some behavior. Admit a lot of people here. Here we go. So delirium triggers, here we go. And so we talked about, other ways to support helping prevent delirium. So yes, although if you get a UTI, it might be sort of hard to prevent, yes. But a lot of delirium, especially for those of our patients, which is the majority that have cognitive decline and dementia, delirium is preventable because it's not always, an infection that's causing it, but little things are enough to throw someone's brain that's already being hurt by a disease like dementia. Little things like, not using their glasses, not having the clock on the wall, not being oriented to like what time of day or where they are. These kind of visual aids, having those shadow boxes with paraphernalia from their family to remind them, where they are. Not expecting them to necessarily remember like their room number or a certain phone number or call button, things like that. So these are all ways we can be creative. So I was hoping too to, if anyone has examples too, please feel free to put it in the chat or jump in. But I was hoping to also hear some examples of how you've all implemented any changes in terms of preventing delirium. And so again, just highlighting delirium, super important that it's an emergency to address. And so you always want to ask, if there's a chance that there's delirium going on, you want to bring in the medical provider, the nurse, whoever's closest to kind of assess. And so these are some of the things we talked about in terms of prevention techniques. Does anybody have any examples of things they've tried since these last few talks? Like making sure a patient had access to a clock or a watch or a calendar, opening the shades, in the morning for patients that tend to like to keep everything dark and get confused. Any examples from the audience?
Hey, Reza, this is Eric. I wonder, and just another question to throw out while people, I'm sure nobody's talking because they're trying to figure out the mute button. Otherwise, they'd all be talking. But I wonder, is it standard of care, like at nursing homes, to have delirium prevention strategies? Like, is that? I mean, it seems like it'd be something that would be sort of, yeah, I guess standard, right? Because the risk is so high for delirium in that population. So I guess, I don't know, I just throw out to everyone.
That's a really good question. Does anybody have any input about that in terms of where you work? And this is a safe, open environment. We're not judging any facilities that do or don't. It'd be really interesting to know.
The mute button's at the lower left.
Someone let us know about your facility. I see Kelly just mentioned notebook to write down medication deliveries and other events throughout the day. That's a great idea, helping giving patients that control, that ability to track what's going on. So yeah, any other, Mike mentions they don't have delirium protocols where they are. Anyone else? Does anyone have a delirium protocol here that they might?
Looks like Julie, you found the mute button. Please go ahead.
I was just flailing.
Yes.
We don't have a delirium protocol per se, but some of the standard things that we do have are calendars in every resident room that we obviously it's kind of like a whiteboard. And the expectation is that gets updated every day with who the staff are that's working that day. We have it in their care plan if they are not appropriate to be reoriented, because there are some people with dementia that will get pretty frustrated if you try to tell them that it's a certain day or time and you're trying to tell them they are wrong. So we do use the care plan for that. Some of our other standards are always to, don't assume that the resident knows who you are just because they've been in your care facility for X number of years. But I kind of like the idea of more of a specific delirium approach.
Yeah, it seems like, appreciate it, because it seems like it's one of those things where the same way you have kind of, the hand washing stations and like exit signs and just all things that prevent, all prevention. It seems like some simple things like calendar, clock, opening and closing shades at the same time every day. So it seems like it, I don't know, might go a long way in making a difference. Yeah.
That was a great point, Eric, that, facilities are all going to vary. So having even just starting with a basic checklist can be super helpful. And some people in the chat here is really helpful input. Samantha made a request for all resident rooms to have clocks. So wonderful. That can be something that becomes sort of like a checklist for almost like a resident check-in. When someone moves in, you can kind of check a few things off that their room has. Keeping fluid intake records. So that's very important. And, in a way, those are sort of a delirium protocol in the sense that, dehydration is one of the leading causes of delirium in older adults. So at least being able to catch when someone's not drinking, because that happens a lot, is because, for most of us, you just assume someone's drinking enough fluids. But then, especially as older adults with cognitive issues, turns out, like, oh, I haven't had anything to drink for 24 hours, and then they get delirious. Ruth mentions no delirium protocols, but they have a process in place to monitor for medical causes versus change in environment. So that's great. So that's also kind of falls under that umbrella. And transition from acute to long-term care. transitions are a very common point of delirium because of that change in environment. It's just, especially the more cognitively impaired you are, any transition, any move can really trigger that. Calendars and clocks in each room, wonderful. If resident works nights, then they may have a different routine to follow. Shades not open during the day, may function on a different schedule than normal. So fair. There are, I've had occasional patients who, were night shift workers for 30 plus years. And there you really have to weigh do you want to help them switch their, or are they just, their clock is kind of there. And so you're right. You want to be mindful of that. If that's at the same time, making sure they're safe and wandering around, not waking everyone up all night. So thanks for that input, guys. That's super helpful. Move this over here. So behavioral emergencies, we talked about this, and we talked about, what to do. And so first of all, how to prevent, and then what to do in situations where people present a risk of harm to themselves or others. And so we wanted to be careful and point out that part of the trauma-informed care framework is really looking at someone and being careful not to call it a behavior as a generic term, but really describing what somebody's doing and really trying to understand where that's coming from. Like Mr. Smith became upset when I tried to, help him get dressed in the morning, XYZ. And so it kind of helps really also put things into perspective and normalize a lot of behaviors, even if they are sort of considered, a risk. And so the emergency part comes in when sometimes it's at a point where we really have to act right away. And that might involve medication. It might involve hopefully a very temporary, quick restraint. But in terms of trying to keep somebody safe. But it turns out something we talked about was preventing is that vast majority of the time, these situations can be prevented. So we spent some time on that, how to approach people in a positive, validating way, listening to concerns. Even for people with dementia, I've had a lot of good luck, even in clinic when they start to escalate and start to get upset. Even with dementia, to kind of talk it out and be able to approach them in a kind of warm and open way and be able to de-escalate. So even for people you may think don't have the cognitive ability, you'll be surprised. I think the human being is always there, so don't forget that. And so underlying causes, this was just a helpful graph to point out that substance use disorder is the single most largest predictor of behavioral emergencies. So just keep in mind, substance use disorder it still counts if we have patients on long-term opiates, long-term benzos. Those are all things, if a dose changes or if there's a withdrawal, if something changes, that can precipitate a massive change in behavior. And keep in mind, that might be all iatrogenic, right? Something that we're doing as a medical provider. It might not be even under the patient's control, so keep that in mind. And so we went into the weeds a little bit about managing behavioral emergencies. If anyone's experienced a behavioral emergency or had this happen since we've talked about this, please mention it in the chat so we can call it out. So yeah, Kelly's mentioning that, they like the chat better. Yeah, actually, and so do the high schoolers I sometimes teach too. So you guys are youth. You can take that as a compliment. That's that you guys are all young at heart. You prefer the chat. So managing behavioral emergencies, really, really important to have a single point of contact. That's what we talked about. Preferably somebody who knows the patient's comfortable with, but avoiding too much stimulation, avoiding crowding, avoiding too much going on. You want to keep things calm, really limit and reduce the amount of stimulation and approach them very calmly. Again, doing these few kind of seemingly simple things will lead to being able to avoid restraints, avoid medication, in certainly some of these cases. So always, for me, that's a big motivator. I feel successful when I can avoid medication for a patient. So I try my best to do that. And this was just calling out in those situations that unfortunately inevitably do come up. If someone needs sedation or restraint, just think to yourself how you would feel, right? If you were feeling sedated, losing control, of your mind and your body due to a medication or feeling restrained. That's traumatic in itself. So it's also traumatic for everyone around us, so just make sure, I would just ask everyone here to make sure you have a debrief, both with the patient to help process, but also with each other, with staff. A lot of times we're just working so hard and moving so fast, we forget to really debrief and talk about these things. And that's something, our leadership should be helpful with too. We talked about psychopharmacology. So really the point of that was pointing, we're all on the front lines. So we all have a responsibility, not just the pharmacist or the provider. We talked about the Beers criteria, which have historically been the helpful list from the Geriatric Society of, what to avoid, what are the medications that are most likely to cause issues. So these were some of the highlights, things like avoiding antipsychotics in Parkinson's disease as much as possible, ones that are a little more tolerable, avoiding certain medications that have bleeding risk, pain medications, being very careful, opiates and benzos, things like that, especially with those of us patients with dementia. So hopefully you guys feel comfortable calling out some of these. And then something I shared, excuse me, I shared with you guys that we posted, will be posted if it's not already, but on the Mount Pacific website where the talks and the slides are, is something one of our colleagues made. Dr. Duong works with us. She's a geriatric psychiatrist, so she sees patients with us in Wyoming and Montana. And this was a really helpful handout. So I just point people to that to use. It has a list. It's a nice, really good, quick reference, just a few pages. And so it has a nice list of medications. So it just helps us all to be vigilant. You don't have to be, I'm not asking anyone here to, memorize this stuff, but you'll kind of get the hang of it, and you'll kind of see what kind of medications are preferred and less preferred. And so honestly, it's perfectly appropriate as a social worker, as a mental health professional, as any kind of staff to say, hey, I just noticed, this patient's been diagnosed with, Alzheimer's disease, and they've been on, Paxil or an antipsychotic, like they've been on Zyprexa for 20 years because they had bipolar disorder or schizophrenia. You can prompt and say, sometimes that just goes unnoticed. I mean, that's just the reality of it. And you can say, well, I wonder, do you mind, ask the provider, do you mind seeing if there's something maybe better or a change that can be made? So a lot of those changes happen thanks to you guys. So just keep that in mind. Now, let's jump into talking about CBT and spend the rest of today focused on this. So let's throw up the first poll question. And who here feels comfortable explaining what CBT is? And I'm not talking about expertise, right? I'm talking about just at a basic level. I'm certainly no expert. I'll mention, I did do additional training. So during my psychiatry residency, I did some focus on psychotherapy. So I did additional trainings in cognitive behavioral therapy. I did training in acceptance and commitment therapy, functional analytic psychotherapy, and several psychotherapies. So there's this sort of traditional psychodynamic psychotherapy, which we started with, and then CBT sort of is a subsequent generation. So we focus on that. And then DBT, dialectical behavioral therapy, also spent time on. So so that's okay. It's about 1/3 yes, 2/3 no. So that's helpful. Thank you guys for voting there. Oops, there we go. So there's the results. And remember, keep questions coming in the chat box if you feel more comfortable with that. So let me turn off the poll there so I can close that. There we go. So let me go back here. Okay. So again, the bigger picture of cognitive behavioral therapy is, and I try to explain this to people, is, we think about Freud and Jung and these psychodynamic psychotherapists back in the day, 100 years ago. And that's kind of where therapy started. And a lot of that was making a lot of assumptions, things that are tied to your childhood, giving the patient a lot of space and time to kind of do exploration. So it was very unstructured, very open-ended. And then, so as time went by, people thought about, well, how can I make something more structured? And also, can I really just, do I need to talk about all that stuff from childhood? Can I talk about the here and now? You know, what's your behavior? What's your feeling? What's your thought? What can I do about it? That's where cognitive behavioral therapy kind of came about in the 60s and 70s and really started to grow. And then when we've heard of, if it's those of you that have heard of DBT, dialectical behavioral therapy, acceptance and commitment therapy, functional analytic, like there's a whole bunch of, you know, cognitive processing therapy. We kind of refer to those as third generation. So there's this foundation of CBT focused on behavior, thinking, thoughts, and feelings. And then these individual, those other therapies all sort of spun out to focus on specific populations. Like DBT came about by focusing on those at high risk for suicide or self-harm. And so they made a CBT that was very specific for that population. And so there's cognitive behavioral therapy for trauma. So it's trauma focused. And that came about focused on younger people generally that had trauma that needed help processing. And so that was just to give you a little background. I hope that makes sense. Please call out if that didn't make sense in terms of like just the overall picture of cognitive behavioral therapy. Is this indicated moderate? Oh, Mike, are you asking, I think, about is cognitive behavioral therapy indicated moderate dementia? I think that's what you're asking. It's a very good question. And the answer is it can be helpful. And I'll actually go over a case in a little bit about good. Yeah. So Mike, I'll go over a little case about where that was actually used, a little case study in moderate dementia where it was helpful, mild to moderate dementia. Great question though, because yeah, you have to be, I mean, it's case by case, but I see where that question is coming from. Now, cognitive behavioral therapy for trauma-informed care or trauma-focused cognitive behavioral therapy, you know, historically that was developed for kids, but more and more we are seeing studies of use in adults and even older adults, like in the oldest old, like people over 80. And that's what we're obviously focusing on because most of us work with the older age group. Now, trauma-focused CBT, again, is this customized CBT to focus on someone helping process their trauma. And so it's manualized, which is helpful because that also makes it more accessible to us. We don't have to go through years and years of training. We can actually help a patient, many, if not all of us on this call, can help a patient through some of these steps in these manuals. It's important to, in terms of delivering a manualized therapy, it's important to have basically a curriculum or an agenda, meaning it tends to be anywhere from 6 to, you know, some of the older patients with dementia I've seen even go to 30, 36 sessions over the course of 1 or 2 years, but that's on the long end. You know, even 6 to 12 sessions tends to be very effective. And the further you go out from that, unless you have a very clear sort of agenda, tends not to add a whole lot. And so in trauma-focused CBT, this acronym practice helps kind of capture some of the pieces. So psychoeducation, which has to do with educating somebody around just generally thoughts, feelings, actions, how that all relates. Obviously, parenting skills doesn't apply as much to our adults. And then we have relaxation skills, very, very helpful. That comes in handy with our older adults. Affective modulation skills, so basically teaching people and older adults how to help process high emotions and how to link healthy behaviors to that rather than unhelpful behaviors. Cognitive processing skills, again, how we think through how we're feeling and the associated thoughts we have with that. Trauma narration and processing, that's the piece that we don't have to use necessarily, especially when we're working with older adults, let's say who have dementia, who may not have as much of a memory or clarity around it. But in those cases where someone is willing and wants to participate in trauma narration, that has to do with building a narrative for them. And then some of this gets into exposure, which we'll talk about. In vivo mastery of trauma reminders. So what are the things that remind someone? Remember, in some of our older patients, if we approach them with restraints, maybe they think they have a horrible trauma from their past and memory. Maybe we approach them, each time we approach them with their medication, we're trying to just administer medication, just doing their job. That's something that is a trigger. So the in vivo mastery of trauma reminders is proactively putting down your trauma narrative, knowing what those triggers are for someone. Maybe it's a certain image. I mean, it could be lots of things, but then exposing them and kind of desensitizing them to that trigger rather than not knowing. offering that trigger over and over again, and then kind of, but not knowing to know, and no one's fault. And then, well, obviously not the parent stuff doesn't apply. And then enhancing safety or future development. So talking about how to help people move forward with that. And then Mike's question, can nurses learn CBT via course certifications? I always found it hard to bring therapists into the nursing home. Absolutely. So part of what I'm gonna focus on right here is some of the things you can do. And in fact, I'll share a little workbook with you guys so that nurses and anyone on this call can feel empowered to do some trauma-focused CBT. So let me skip to this next slide. So let's quick poll. Please give an example of a CBT technique you have used with a resident or patient. Of course, if you haven't, no problem. If you have, go ahead. Feel free to jump on verbally. This is, I know people are afraid of that mute button, or type it in the chat. Give you a couple of minutes to type in, and we'll come back to this. But go ahead and share any kind of CBT technique, even if you think it wasn't CBT. Just even throw it out there, and we'll talk about how it might fit in. So trauma-informed care, these are the CBT based treatments, a little bit of more overview. And so that top half is for adults. The bottom half is the child-focused models, but I left that because the trauma-focused CBT that we just mentioned at the bottom, that has growing evidence that it is helpful with adults as well. So although it's designed for children, it can be helpful for our situation as well. So that first one, prolonged exposure therapy, this might be one of the most effective for us to use in our settings. And that has a lot to do with being clear about the trauma narrative, not necessarily reliving, but at least having a good understanding of what someone's triggers are. So what are the kinds of things that bring up a certain feeling or reaction? And so, excuse me. And so it does focus on PTSD education, but it doesn't have to be someone with a formal diagnosis of PTSD, because oftentimes that's missed. So someone may not have that. And, you know, I don't want you to worry about having to find a psychiatrist to give that diagnosis, but you can absolutely still make progress and focus on prolonged exposure. So you can see there, it mentions 8 to 15, 60 to 90 minute sessions that occur 1 to 2 times a week. There's more and more research done on breaking this up into smaller chunks, and it's still being effective. So you don't have to necessarily say, oh, I got to find 90 minutes. That's not the case. You can break this up depending on the patient's functional state. You can also leave some of this as homework, which is available in various workbooks and questionnaires online. But this is really one of the ways we can help our older adults be less sensitized and move forward and do the things they want to do. The eye movement desensitization and reprocessing, that's more of a formal process that requires some equipment. So that's something you can, I have plenty of patients who have done this, but that requires a little more resource. Seeking safety. So that's often something that comes in handy, especially with our older adults that have still very active reactions to trauma. So it really helps them kind of figure out what's a safe environment, what's not, and what things they can do even when they're not in their own home. Maybe they're in the nursing home, things they can do to help them have a sense of safety. So these are just some of the models, but these are all types of cognitive behavioral therapy. So keep that in mind. These are all subset of CBT. CBT is the umbrella. They're just, you know, various people with various takes on it. Now, here's let me actually take a pause and see what a couple people have mentioned. So Mike mentioned, yeah, I'm going to leave your room for X minutes until you stop swearing at me. So right, so that's a behavioral intervention where you're looking at something. So giving someone attention, spending time with them, that's a positive reinforcement, right? So you're using that as a withdrawal of that as kind of a motivator. So that is a CBT technique. So because that's focused on, okay, you want me to be here, you want something, and you're putting boundaries around what kind of behavior is acceptable in order to receive that positive reinforcement. Cynthia mentions she helped a woman in a nursing home understand that her alcoholic son probably had a genetic predisposition to it, which helped her change her belief that she failed him as a son. She became less depressed and shameful. Very good example. That is a really, really good example of cognitive restructuring, reframing. There's a few different terms, but reframing that thought process. So absolutely right. So many of us, including myself included, we'll live through life and have a narrative that ends up not being based on facts. It's based on our emotions. And so a natural emotion of feeling really, really sad about her son led to likely inaccurate thoughts. So that it clearly is not one individual's fault if someone's using a substance, although it can feel like it is. So great example, Cynthia. And Eric, thanks for mentioning online courses there. And I will have some resources at the end and some stuff I will share with you guys. Deep breathing, guided imagery, burning, pastoral. Nice, Sam. That's perfect. Good examples too. Those are all central. And in fact, on this slide here, you'll see some of these called out. So this might be kind of just like a rough schedule. If you're going to approach someone with a CBT, a trauma-informed care kind of stance, again, I encourage you to, of course, have a manualized approach, but have this jotted down. Have like a little structured approach, because you don't want to, like I said, you start it right and then like forget, and then 3 weeks later you're approaching them. If you feel like you can spare 10, 15 minutes and every once or twice a week approach someone and really do this in a formal kind of way, I think it's pretty likely you're going to see some benefits. So you can see here one example. This is like an example of how I've done in the past. And so you can start by education about intervention. This could be someone, let's say, that fell in the nursing home and has a fear about falling again. And that fear is both based on reality, because falls may happen again, but also keeping them much more immobile, much more sedentary, and less likely to do the things they want to do because their fear is kind of blown out of proportion. So you would start by educating them about anxiety and the work you're going to be doing. You're going to start right away, the first session, and in pretty much every session after that, doing relaxation, like diaphragm breathing, teaching them that I'm talking about something anxious, and immediately giving them a tool that they have full power to use at any time. And then you can see these first few sessions, you can use imaginal exposure. So it might be with them just sitting down, but in a chair and thinking about, let's walk through, you walking down the hallway and feeling scared. Like maybe they see some few people walking around, they feel like they're going to get bumped, or they feel like something's going to happen. You can use just guided imagery. So you can talk them through it with their eyes closed or with their eyes open and help them. That begins the exposure process, right? So again, and each time you do that exposure and you see that anxiety or that kind of heart rate, however you want to look at it, increase, hit them with a relaxation technique, diaphragm breathing, guided meditation. And again, you don't have to be sitting there for this whole time. You could throw on a YouTube of a guided meditation and then leave the room and come back in 5 minutes. Let them do that. I want to find ways for everyone here to feel like I can do this. I don't need to be a therapist that has to sit here for an hour. So you can kind of spend a few minutes, do the exposure, and then leave them with a meditation. And as you proceed, you can see by session 3 or 4 as an example here, then the exposures take the concrete approach. So you would then have them actually get up. You would take them for a walk, and you would start to do that exposure. And again, as soon as that their adrenaline starts to their anxiety starts to get off the ground, you hit them with a pause and some relaxation exercises. So you see the cycle. You're exposing them to a stress. I'm scared of falling. I'm scared of like a certain resident. I'm scared. Something's a trigger. You slowly expose them, and then you give them that empowering understanding that, oh, I can actually do something about my anxiety and my ramping up emotions right now. And then you can see some of the other things sprinkled in here, like social support, behavioral activation. So showing someone who tends to isolate, for example, how to reach out for help. For example, someone who's afraid of falling, maybe they learn how to take walks with a friend or with somebody that helps them feel a little more safe. That cognitive restructuring, positive thinking, that's like that example we just heard from Cynthia. So positive thinking. So a lot of times, right, you're thinking about, you ask somebody like, oh my God, I fell, like, I don't know if I'm going to live much longer. Like, I don't know if I can walk again. God, if I get up right now, like it's so likely that I'm going to fall again. So cognitive restructuring is interviewing them, not telling them, but asking questions that can help them understand that what the real risk of a fall is. So asking questions like, so before your fall, before you had this fear, what was your estimate of how likely it was you were going to fall? And they might say, it wasn't very likely, maybe 1%, 2%. And you kind of go down the path of asking, well, how has that changed now? And helping them, and that will help them realize that, I fell once and my like estimation just totally went out of proportion because of the anxiety. So trying to help them understand that without the anxiety, their risk maybe didn't actually change. So those kinds of things are really helpful for the cognitive restructuring. And again, that relaxation stuff, which we can all do, very, very helpful. And please throw in any questions you have along the way. I hope this is making sense. I'm really hoping to make the process of cognitive behavioral therapy with a trauma focus feel very accessible. I mean, this is really something that I wanted to throw up stuff that we can all do here. This doesn't have to be a referral to a therapist. It certainly can be, but that's accessible, especially through telehealth now, but it doesn't have to be. And so you can kind of see, you go through this exposure, imaginal exposure, real exposure, cycling with relaxation, talking about behavioral activation, social support, positive thinking, doing this cognitive restructuring, asking them. And that cycle really does desensitize, reduces that risk of anxiety and avoidance. So this is an example of somebody like doing how the exposure would ramp up from 1 to 10 with somebody who has a fear of falling, for example. Of course, I write down there, get clearance from PT. This is something you want to make sure they're physically safe, because if they fell and actually they have an injury, of course, we have to balance that. But they might walk, and you can adapt this to be in the nursing home, right? Not to the corner store, but walking down the hallway, holding somebody or holding some assisted device. And so on, and exposing them to a little more independence each time. Again, with the cycle of showing them that they have some control, doing those relaxation exercises, having a few minutes of cognitive restructuring, asking them, eliciting how they felt, and then exploring with questions how they felt and how that links logically to their feelings versus reality. And so you can kind of see, you can kind of just jot this down with a patient and customize it to them and say, this person's afraid whenever this one resident is around. So I'm just gonna do like a quick 6-session, few minutes of exposure, start with imagining and kind of ramp up. But that way it'll help you kind of keep track and be able to have a more formal approach. So correcting cognitive errors. So we kind of were touching on this in that we were talking about how to help someone restructure their cognition. So some of those examples I already shared, just to really hammer this in, this is one of the most powerful portions of CBT, cognitive behavioral therapy. So what we tend to do as humans, and this is helpful if you think back to how we started as humans, is think in binary terms, in terms of this is dangerous, this is not dangerous. Because guess what? For hundreds of thousands of years, it's a tiger, it's not a tiger. It was, rock's gonna follow me, it's not gonna follow me. Not a lot of wiggle room there, right? But guess what? Now in 2021, we live in a very gray world. There's very little time, there's very few times where it's binary. So now that my mammalian brain, my kind of, old protective brain jumps in, is like, oh my God, I can't walk. It's scary. Well, no, we can actually coach patients to then remember, and this is actually DBT, dialectical behavioral therapy, is very good at this, but cognitive behavioral therapy in general, everything's a continuum, everything's a spectrum. So there's times when I can have appropriate, carefulness, and then times when I'm probably overcautious. And so the key here is you validate that their assessment. So you validate that, oh, of course there's a chance you might fall. I get that. And that is scary. I don't want to fall because, man, I might end up in the hospital, I might break my hip. But then you after validating, you can have this open-ended conversation with them to help elicit what it is that they may be over subscribing to, like overvaluing. So what they tend to do is treating feelings as facts. So if I feel nervous about walking, there's a danger. That's a fundamental CBT point there, is just because you feel nervous, helping someone understand doesn't mean there is an actual danger, right? Because think about how powerful our brains are. I'll sit right here in my office and feel anxious. no one's trying to hurt me, no one's around, but I'm feeling anxious. So helping residents in our nursing homes understand that gives them a lot of power. Picturing the worst, right? We tend to catastrophize. So we always think about, oh, I'm gonna jump to the fall because that's what's gonna happen, not the million steps in between that helps focus on. So, oh, you're walking, but let's say you're walking with a cane, you're walking with a friend. If you were gonna fall, would you grab onto them? Would you grab onto the wall? Would you just maybe fall, do a control thing, fall to your knees? Would you? There's sort of, right, all these other in the middle steps that you can help them realize are there, that it's not a black and white. I'm walking, I'm on the ground, and my hip is broken. And then this intolerance of risk. So again, helping people really understand, just like me right now, being relatively healthy, I don't have complete control. I never do. I could, fall down the stairs right now and, hurt myself. So kind of going through and that's okay. Sort of understanding that's a risk, using that relaxation techniques, the meditations, the breathing. Again, as you're going through these steps, if there's anxiety rising up, pause, bring it back down. You want to go through these conversations in a very calm environment. So if someone's like losing it, cut it off, do relaxation, or come back another time, but help them bring it down. That's what makes a big difference. We'll wrap up soon. I know we're almost out of time. Poll 3, what is the biggest predictor of CBT efficacy? Fidelity, and by fidelity, I mean like how true do you stay to the manual? Like, do you follow it to a T, or do you kind of go off and start having some chit chat? It's very easy to do. Having your training and certification, the therapeutic rapport, relationship with the patient, or the patient willingness. Go ahead and answer. I'm gonna say thank you to Casey from Wyoming for being on video, so I don't feel so lonely. Appreciate it. Thank you for voting. It looks like I almost tricked you guys, almost, but yeah, patient willingness is of course a big factor. I mean, if they're not willing, you're absolutely right. In studies, what's interesting is, beyond the sort of fidelity and training and this and that, it's the therapeutic relationship that predicts outcomes the most. So what does that tell us? That tells us that the trauma-informed care is super important, because the more we are validating and have a good relationship with the patient, people might not realize this, you have that much power that will impact their outcomes. And so we have a lot of power over that. So I just want to end with that. If anyone wants to share any experiences or ask any questions, please make sure to fill out today's survey that's just got posted in the chat to make sure we can track your attendance and for CME credits and all that. Thank you for that comment, Dawn. Any questions, jump in verbally or in the chat. Again, I want you to leave today. The goal is you're going to leave today and say, hey, I have a patient that is afraid of X. I think I can kind of jot down like a 6 or 7 session, 6 to 12 session, a few minutes here and there, and sprinkle it around the day. I mean, we got to do what we can with what we have. So I'm not asking everyone to like hire a therapist and really do it formally. Yes, that would be ideal, but we're going to do what we have to for our patients. And so I want people to feel like, I know how to do a little bit of cognitive restructuring, interviewing with that patient, talk about their fear. I know how to do some relaxation. And I also know how to do a little bit of healthy exposure, little by little. And if you fall back if you get nervous and if you fall back and you're like, oh my God, this person's getting a little bit upset, even with the imagery, fall back to that relaxation, jump into a deep breathing, pull up a guided meditation on YouTube. If you do that, that's always your safety kind of eject button. You can always pause and help bring things down. And then of course, with your colleagues, asking for advice. Any questions? Looks like Casey has a question. I tried. Any questions? And we'll get this stuff posted online. I do have a little trauma-focused CBT workbook I found online. So I'll have that posted too, just because it has some kind of nice materials and some nice ideas to help people do this at where they work. No questions. This is a quiet one. We sure there's no questions? Okay. We can dismiss then, and join us in a couple weeks for the last session. We'll kind of be doing a wrap up overview and talk about family and caregivers. All right. Thanks, everybody.
Thank you.